Let's begin with the foundations. Welcome to another lecture. Today, let us discuss cardiomegaly, that is to say, the phenomenon of an enlarged heart and the many stories it tells about pressure, volume, muscle, and time. Hello, I'm Professor Alexei.
Hello, I'm Priyanka. I'm Professor Alexei's teaching assistant.
To frame our discussion, we should define terms in a way that is, well, actually useful. Cardiomegaly, in simpler terms, means the heart appears larger than it should. Often it is responding to chronic work it has been asked to do. High blood pressure makes it push harder. Coronary artery disease makes surviving muscle compensate for injured regions. And valve disease or congenital problems can create long-standing overloads. Occasionally, the heart is larger for healthy reasons, as in highly trained endurance athletes. We call this athletic heart syndrome, and it is typically a benign, reversible adaptation.
So, in scientific language, we would say cardiomegaly reflects myocardial hypertrophy or dilation. Hypertrophy for pressure overload, dilation for volume overload or intrinsic muscle weakness. And these patterns show up on imaging and link back to causes like hypertension or cardiomyopathy. Is that fair, Professor?
Precisely. We observe two dominant morphologies. Dilated cardiomyopathy stretches chambers and thins walls. Hypertrophic forms thicken the ventricle, often inherited in the hypertrophic cardiomyopathy family. Both can enlarge the cardiac silhouette. Both can impair pumping, albeit by different mechanics. Fundamentally, as sarcomeres lengthen or thicken abnormally, actin-myosin overlap becomes suboptimal, and sliding filament efficiency falls. The pump then struggles and the rest of the body notices.
Why does this matter right now? Well, because cardiomegaly can quietly progress to heart failure and is associated in studies with a higher risk of sudden cardiac death. Early detection and management can change the trajectory, even when people feel fine at first.
It's important to understand that historically, we were not always precise about causation. Many cases were labeled idiopathic, which is the polite way of saying we did not know. Over time, we linked enlargement to hypertension, coronary disease, valvular regurgitation or stenosis, congenital and genetic factors, sleep-disordered breathing, sustained arrhythmias, toxin exposures including alcohol, cocaine, and anabolic steroids, endocrine and infiltrative diseases like thyroid disorders, hemochromatosis and amyloidosis, infectious myocarditis including HIV and Chagas disease, renal failure on dialysis, and pregnancy-associated cardiomyopathy around delivery. Each of these pushes or stretches the heart in its own signature fashion.
Maybe the most surprising piece is that many people feel nothing for a long time. Then, when symptoms arrive, they look like heart failure, shortness of breath on exertion, cough when lying flat, palpitations, chest pain, leg swelling, fatigue, even fainting. It makes routine evaluation and risk factor control seem like less optional and more essential.
Speaking of detection, in 1919, the cardiothoracic ratio on posterior chest radiographs was proposed. A ratio exceeding 50% was treated as suspicious. For a century, this simple geometry triaged countless people toward definitive imaging. Today, we complement it with echocardiography, which visualizes chamber sizes and valve function directly, ECG for rhythm and clues to enlargement, stress testing to probe performance under load, CT and MRI for detailed anatomy, targeted blood tests, and, when the differential remains stubborn, catheterization or myocardial biopsy. It is worth noting that pericardial effusion can mimic an enlarged heart on X-ray, so ultrasound or cross-sectional imaging helps us avoid category errors.
On a related note, in pop culture, the topic sadly surfaced with autopsies of Jimmy the Rev Sullivan and Taylor Hawkins. Reports noted cardiomegaly, with drug exposure and the intense physical exertion of rock drumming potentially compounding stress on the heart. It is a reminder that physiology, lifestyle, and toxins can overlap in dangerous ways.
For completeness in forensic pathology, heart weights above roughly 399 grams in women and 449 grams in men are taken to indicate cardiomegaly at autopsy. Naturally, in the living, we prefer non-invasive measurements. The dead are not ideal candidates for follow-up, as it were. If I may share a brief personal connection, as a young researcher, I became fascinated with the geometry of the cardiothoracic ratio, and then with how echocardiography could turn a flat shadow into a four-chamber, valve-by-valve map. It was to me like moving from a chess problem diagram to analyzing a full game. Patterns emerged, strategies became visible, and the heart's compensations could be inferred rather than guessed. This brings us to three larger questions: one historical, one counterfactual, and one very much open today. We will use them to connect mechanisms, measurement, and meaning.
Professor, may I ask the historical one first? How did early medical practitioners understand the causes of cardiomegaly?
Before modern imaging and widespread blood pressure control, enlargement was often a radiographic curiosity or a post-mortem finding. Many cases were catalogued as idiopathic. Over the 20th century, epidemiology and pathology converged. We mapped long-standing hypertension to left ventricular hypertrophy. We learned that coronary artery disease causes regional scarring, after which the remaining muscle dilates in compensation. We saw valve regurgitation produce chronic volume overload and dilation, and we identified congenital and inherited cardiomyopathies as distinct entities rather than miscellaneous categories. In simpler terms, the silhouette gained a backstory.
Professor Alexei, could you clarify how these historical misunderstandings impacted treatment approaches?
When causation is vague, therapy becomes blunt. Early on, patients were advised rest. Later, digitalis and diuretics were used broadly to relieve symptoms, but specific prevention lagged. Without recognizing hypertension as the driver, there was no targeted pressure control to prevent hypertrophy. Without appreciating valve regurgitation as the engine of dilation, surgery came late, if at all. Without separating athletic heart from pathology, some athletes were mislabeled, and conversely, some dangerous cardiomyopathies hid in plain sight. As classification improved, we added ACE inhibitors, ARBs, and beta blockers to alter remodeling. Anticoagulants in selected cases to reduce intracardiac thrombus risk, pacemakers for conduction delay, ICDs for arrhythmic risk, and operations from valve repair to bypass, with LVADs and transplant anchoring the far end of the spectrum.
To shift gears a bit, what if the cardiothoracic ratio had never been proposed in 1919?
Counterfactuals are pedagogically useful. Without the cardiothoracic ratio, large-scale screening in armies, factories, and clinics would have lacked a quick gatekeeper. Many people with silent enlargement would have blended into the crowd until symptoms became unmistakable. Practically, referrals for echocardiography would have been fewer and later. Pericardial effusions might have masqueraded longer, and public health responses to hypertension and valvular disease would have lost an early, visible sign that something was amiss. We cannot compute the exact delta in mortality, but delays in detection typically translate into more decompensated heart failure, and arguably worse outcomes.
Professor, Do we see similar tools being developed today that could have as much impact?
We do see evolution rather than revolution. A newer two-dimensional cardiothoracic ratio uses areas rather than diameters on chest X-ray. Echocardiography is ubiquitous and smarter about quantifying chamber size and wall thickness. CT and MRI provide high-resolution structure. In addition, automated analysis, call it algorithmic triage, of standard imaging and ECGs is emerging to flag enlargement or high-risk patterns, funneling attention efficiently. The spirit is the same as 1919. Use a fast, widely available screen to decide who needs definitive testing.
Building on that, what are the most pressing unanswered questions about cardiomegaly today?
3, at least, loom large. First, a substantial fraction remains idiopathic. We suspect underappreciated genetic variants, prior viral myocarditis, or toxin exposures, but hard attribution is elusive. Second, the link to sudden cardiac death is supported by studies, but varies across etiologies. Quantifying individual risk with confidence remains unsettled, which complicates decisions about ICDs. Third, distinguishing physiological remodeling in athletic heart from early dangerous cardiomyopathies can be challenging on first pass. We rely on careful history, ECG, and echocardiography, but gray zones persist. Across these themes runs a common thread: better phenotyping and smarter risk stratification.
Professor, what areas of research do you think hold the most promise?
Genetics and personalized medicine are well positioned to help. Pairing genotypes with detailed imaging phenotypes may turn idiopathic into identifiable subtypes. In imaging, refined echocardiographic measures and MRI tissue characterization can separate healthy adaptation from occult disease earlier. On the clinical side, integrating rhythm data with structure, because enlarged chambers invite arrhythmias and thrombus, could sharpen who benefits from anticoagulation or device therapy. And, lest we forget, prevention research remains impactful. Rigorous blood pressure control, treatment of sleep-disordered breathing, avoiding cardiotoxins like cocaine and anabolic steroids, and addressing valvular lesions in a timely fashion can prevent the stimulus for enlargement in the first place.
Before we wrap up, could we quickly summarize practical takeaways for someone listening who is, wondering what to do next?
Certainly, if cardiomegaly is suspected or found on a chest X-ray, confirm with echocardiography to identify which chambers are enlarged and whether valves leak or narrow. Assess symptoms, palpitations, exertional breathlessness, swelling, fatigue, or fainting warrant prompt evaluation. Work backward to causes. Check blood pressure, lipids, glucose, thyroid. Consider sleep apnea. Review substances and medications. Look for coronary disease or valvular pathology. Management spans diuretics for congestion, ACE inhibitors or ARBs, and beta blockers to improve remodeling, digoxin in selected heart failure, anticoagulants when clot risk is meaningful, rhythm control as needed. Devices in surgery are escalations when indicated. Pacemakers for conduction, ICDs for dangerous arrhythmias, valve repair or replacement, bypass for coronary disease, and in advanced cases, LVAD or transplant. Meanwhile, lifestyle measures, cessation of smoking, prudent alcohol and caffeine intake, healthy weight, abundant fruits and vegetables, adequate sleep, and regular exercise reduce the chronic loads that enlarge the heart. In athletic heart, screening ensures physiology is not masking pathology, and detraining typically reverses the enlargement.
So, I guess that kind of sums it up. Cardiomegaly means an enlarged heart, sometimes benign, as in athletes, often a red flag for conditions like hypertension, coronary disease, or valve problems. Historically, we moved from idiopathic labels to specific causes. A century ago, the cardiothoracic ratio helped us screen. And today, open questions about genetics, sudden death risk, and athlete screening are driving research.
In conclusion, if this topic has piqued your curiosity, a natural next stop is dilated cardiomyopathy and its contemporary treatments. It is, as we have noted, the most common structural pattern of enlargement. Thank you for lending us your attention today. May your blood pressure be well controlled, and your hearts figuratively large and literally well-sized.
Thank you, Professor.